this Unit 2D is going to start out by talking about pain in labor, and then we'll move on to assessment of high-risk pregnancy. So let's begin by talking about pain in labor. Now, both the American Society of Anesthesiologists as well as the American College of Obstetricians and Gynecologists state that the laboring woman should be offered pain medication when she desires relief. So we need to move away from the concept of everybody gets the same drug, everybody is going to get the same amount of medication, or the idea that every woman needs medication. The idea about pain control really needs to be an individualized approach, and that should be discussed between the woman and her provider prior to her arriving to the hospital in labor. We need to remember that each woman's perception, just like each individual patient's, and like anybody else, each individual woman is going to have a different perception of pain. She's also going to have perhaps a different preference for her pain control. Now, when we're starting to talk about research in modern medicine and really where individualized medication therapies are going, we'll talk about how genetic makeup is going to directly influence, perhaps, in the future, how we time our medications, how we dose our requirements for many of those. For example, we already know that white and Asian women who are carrying the G118 allele will require more pain medication, or traditionally require more pain medication compared to Hispanic and Black women that do not carry this gene. So really just being aware that we need to take an individualized approach to our pain management, even when we're considering that a lot of doses and a lot of medications are standard when we're talking about pain relief during labor. So we need to talk about the two different origins or sources really for pain during labor. We have a visceral response and we also have a somatic response. So the visceral response, as I mentioned in the 2A lecture, you have that visceral response during dilation and effacement. You have that during the first stage of labor. Remember, that's what's occurring there. We have that distension of the lower uterine segment. Everything is lengthening out. We have the stretching of the cervical tissue during that dilatation and effacement process. And we also have, as the infant or the fetus is coming through the birth canal, we also have pressure and traction placed on adjacent structures within the pelvic cavity itself. The pain impulses during this process are being transmitted via the spinal nerves, which is important when you consider when we talk about epidural and how that controls pain, or how we use that to minimize pain. But we also have accessory lower nerves, accessory lower thoracic nerves, upper lumbar sympathetic nerves that are also involved within this visceral process. The woman really complains usually about pain being over the lower portion of the abdomen during this phase. We also have referred pain. So in this case, the pain, the origin state is still going to be the uterus. You're still going to have the fundus contracting, sending that wave-like contraction over the uterus, but the referred pain means that a woman might feel it radiate to the abdominal wall, the back, the lower back especially, the iliac crest, back where we had those kind of that false hip area, the gluteal area, and even complaints about pain in the upper thighs. Pain is usually only felt during the contraction itself, as we've discussed before, and usually during that relaxation period between contractions, the woman doesn't feel that pain. With that being said, there is a caveat to that. Women who are experiencing what they call back labor, in which the fetus is in a posterior position, may be in continuous pain, as that infant just continues to put pressure on that lower back. Now, the somatic pain is usually felt during that second stage of labor. So again, what is the second stage of labor? Go back to your 2A lecture. So we are fully dilated, right, until the time that we get that baby actually expelled from the cervix. So we have sharp, burning, localized pain as the infant makes its way through the birth canal. Now, you may have had cervical dilation. That may have all been, you've got that relaxin hormone, that estrogen that has kind of made the pelvic cavity a little bit more supple, might stretch a little bit to allow that, 9.5, if not larger, centimeter biparietal diameter of a fetal head to fit through the vagina. But you're still also going to have that very sharp burning and localized pain as the fetus makes its way through. Remember when we talked about an episiotomy? Again, these are all going to be, you're going to still have pain right at the vulva as the baby stretches that area. You're going to have distension and traction placed upon the peritoneum and the uterocervical supports. People are going to complain about pressure on the rectum and the bladder. Remember, we talked about this in that 2A, really how that fetal head during that crowning phase is going to be putting the pressure on the rectum as well. Then we have to talk about the lacerations, okay? So if a baby's head is having difficulty passing through that perineal area, okay, and then at the same time, you've got the mother bearing down during these contractions, and you also have those involuntary contractions, of the uterus, of the myometrium. One way or another, this baby is coming out. So with that force, the woman might tear, okay? So that would be an example of that somatic pain. Again, as I already mentioned, epidural. Perhaps we go ahead and we do we force a laceration there. So either way, this somatic pain, so now this is not going to be transmitted through the spinal nerves, right? This is very localized pain. This pain is transmitted through the pudendal nerve, and from there it reaches into the spinal column. Somatic pain is different than visceral in that somatic pain will respond to localized therapy. So we'll talk about that here in a little bit. Some other factors that influence a woman's perception of a pain response are going to include things, physiologic factors. So here we've got that whole uterine contraction, physiologic, okay? Dilatation and effacement occurring. But then we throw in there some fatigue, some anxiety. We are all aware of how that mental health, influences pain response, like it heightens that pain awareness. You throw in a woman who is at 10 centimeters. We already talked about that irritability is very common during that transition phase. So you throw that anxiety on there, and now everything just seems even worse than it already is. Let's also talk about that interval and duration of contraction as regards to physiologic factors. If we have contraction one after another, and that laboring mother does not have a lot of rest in between, she's going to fatigue even more quickly. She's not going to have a chance to mentally as well as physically regroup. The size and the position of the fetus. Remember, if it's a very large fetus, we're going to have concerns as it tries to transverse its way through that birth canal, as well as positioning. Remember, I just mentioned about an infant or a fetus that's posteriorly positioned and what that does for the mother as far as back labor. Feeling that baby descend can also be a physiological factor when we're talking about pain control in labor. The maternal position. If mom is unable to get up and move when she wants to because, she's had a spinal, for example, and she's completely numb, well, that's not going to help her. It's going to limit her mobility, and it's going to make her positioning even more difficult. Again, influencing that physiologic response. Then let's talk about endorphins. So again, endorphins are to some extent, I mean, these are endogenous endorphins. So then it goes back to that physiologic, okay? So we have endogenous opioids, these beta endorphins that are secreted by the pituitary gland, which is why people respond to the opioid pain medication, okay? Our body already has, endogenous opioid receptors in the brain. These act on the CNS and the peripheral nervous system to help reduce our perception of pain. These levels of these beta endorphins naturally increase in pregnancy. And what is so interesting about it is that, okay, why would we need to increase our beta endorphins during pregnancy? Well, it might help that woman, that laboring mother, to raise her pain threshold and tolerate pain just in general better than if she didn't have that increased level. So those are all some of those physiological factors, but physiologic isn't the only factor, as you guys can see here. We've got culture. So different cultures, religions, perceive, interpret, and respond to pain differently. For those of us who have worked with different cultures, worked with different ethnic backgrounds, we know this to be very, very true. Again, as I mentioned prior to this discussion, we talk about how white and Asian women carrying those alleles might require different amounts of pain medication. So genotyping is providing us the evidence that we've known all along anecdotally that different cultures respond to pain differently. Anxiety, as I already mentioned, we have that catecholamine surge, which increases the stimuli in the brain when we have anxiety. And again, that pain perception is magnified. And the other area that is also affected is muscle tension, which greatly increases. So if our laboring mother has a ton of muscle tension, then it's going to be more difficult for her to relax during that momentary pause between contractions, which again is going to elevate her pain response. When we talk about previous experience, what we're talking about here is if a mother had a bad labor experience before. A bad labor experience doesn't necessarily mean, well, she had a terrible provider who didn't listen to her. She had a terrible anesthetist who didn't get her epidural placed right and she felt everything. But also if she had a premature delivery, what if she had a fetal demise? She's very hesitant about this delivery. What if she tore terribly and had a 4th degree tear the last laboring process? All of that previous experience can increase apprehension. And so that can affect a woman's response to pain as well. So then we're going to talk about this gate control theory here. Now this gate control theory of pain, basically what's saying is that the pain that a woman experiences during the laboring process, which we already talked about, visceral somatic, okay? So you're going to have pain. It's what it is. It's the body's response to what's happening. So this pain is going to be felt and it is going to travel along the sensory nerve pathways to the brain. But here's the deal. This gate control theory of pain says only a limited number of sensations or messages can arrive at one time in the brain. The brain can only handle so many pain receptions, okay, at a moment. So what we can do is, using this theory, we can use non-painful distractions to close off that gate to inhibit some of those pain stimuli from actually being perceived by the brain. So things like motor activity. So if we want to do our Lamaze breathing, our deep breathing, doing that hee hoo hoo, which we'll get to here in a moment here, doing that motor response, getting that involved. Cognitive activity, so things like concentrating really hard. Some people concentrate on a dot or a picture, some object in the room, helps keep that gate closed, and with that closed gate, then we have decreased perceptions of pain. We're also introducing the brain to positive stimuli by utilizing all 5 senses that we have. And so the brain, we are wired to accept more positive stimuli. We, regardless of what we may think, our brain actually wants to think positively. So it's going to take those positive responses over the negative responses and over those negative stimuli. That's all fine and good. That gate control theory is, we definitely want to implement aspects of that into our birth plans and into our approach to our patients in the laboring as they labor. But the fact of the matter is that more focus is needed, more effort is needed towards the end of that labor, during that transitioning process, during that stage 2 of labor, in order for that gate control theory to really work. And if we have any kind of a loss of inhibitions, then we potentially are going to lose all of the positive effects that we had here. Not all of them, but we're not going to be able to perhaps maintain that as much. Comfort, support, environment, these all kind of run together. So we're trying to have this calming atmosphere, especially by others, and rather than the hospital staff. Now, in our COVID world, during the pandemic, at the height of the pandemic, it was very difficult because some hospitals were not allowing a support person to be with the laboring mother, and the hospital staff had to take on that role. Try as we might, we physically, emotionally cannot replace that laboring mother's support person. We know that if we are able to reduce the use of analgesia and anesthesia, that we have evidence that says that we have better birth outcomes. And that evidence is indicated by higher APGAR scores, lower cesarean rates. So if we can have that comfort and support, we really need to integrate that into the birth. A doula is a non-medically trained individual who is there to support the laboring mother. The doula has received training to integrate all of the methods like touch, positive pressure, really doing a ton of support just for that laboring mother, and has experience with other laborers in providing that as well. And then environment. So environmental wise, there are some transitions that we're starting to see here in America. The alternative birthing centers, they really focus on providing a comfortable, supportive, and low intervention birth experience. So these are really home-like settings that a woman can deliver the baby in. As you can see here, you've got this birth sling. So the woman might be pulling on this. She might be resting in that. We've got the birthing stool here. One thing you will notice is that there's no medical bed. You're not going to see stirrups. The jacuzzi tub here is here as well. For those that would like to participate in a water birth. So there was one in Madison that unfortunately did close within the last couple of years. These alternative birthing centers really need to be normalized in our American culture. This particular one in Minneapolis sits right across from, I believe, from the Children's Hospital, with the concept and with the idea, and this is staffed by midwives, the concept and the idea that if there were to be any complications during delivery, these patients can be admitted very quickly over to that hospital and have that inpatient setting if needed. Now, these alternative birthing centers will only accept low-risk pregnancies. They're not going to take anything high risk. And then as well, like I said, they have admitting privileges, so it definitely makes things easier when push comes to shove. But this woman is going to, if you have a bed that's large enough for your support person to crawl in bed with you, your partner to be in bed with you, you're going to have a more relaxed approach to your labor and delivery versus the bright lights and the sterile environment of the hospital. So let's talk a little bit about non-pharmacologic pain management. In addition to, trying to provide that comforting, soothing environment, we're also going to use some relaxation and breathing techniques. And this is, the whole concept of this is to maximize upon that gate control theory of pain. It provides a sense of control, aids in pain management goals. This is a really low risk intervention. So if a woman wants to give this a go, then definitely let's try it. In fact, in labor number 2, I had not had any additional Lamaze breathing technique classes or anything like that. And I distinctly remember the nurse standing next to me next to my head, helping me to control my breathing during this way. It also keeps the woman mobile, and it keeps her actively involved. So if we don't have to dope her up with pain medication and keep her, calm, because we're concerned that she's going to be now a really super high fall risk, if we're able to maintain that pain using something as simple as breathing, then we're going to actually reduce the duration of labor and also the risk of cesarean delivery. Remember, the fewer interventions that we do, the more of those natural processes that take over. So let's talk about, we've got some controlled relaxation techniques. These really focus on that focal point and using distraction. Other things are feedback mechanisms, like saying relax at the onset of a contraction and throughout the contraction as needed. So that support person right there at the head saying, relax, relax, provides that feedback mechanism to the brain. Again, letting in that positive stimuli. There are different types of specifically patterned breathing approaches. There's the Bradley method, there's the Lamaze method. Either way, the whole idea is to reduce tension and stress, use that attention focusing and distraction. During that first stage of labor, we're going to promote relaxation of the abdominal muscles. During that second stage, we're going to use the breathing to increase abdominal pressure to expel the fetus. All types of the breathing is going to start with a deep cleansing breath. The thing about pattern breathing is that as labor progresses, a woman will naturally move from a slower pace to a modified pant-blow pattern. And obviously, the most difficult part of labor is going to be during that transition phase, during that dilation, from 8 to 10 centimeters. The only concern that we do have about this is we need to watch our patients for that hyperventilation. So you can have a slow-paced breathing here where you're going in 2, 3, 4, out 2, 3, 4 for those counts. A modified breathing, and then that pattern in, out, below. Okay. Here's another one where you see over here on the right diagram from Alina and out of the Twin Cities. You see that deep relaxing breath. As the contraction reaches the acme point, we've got a shortened pattern breathing, and then we move into the hoo, hoo, hoo mouth form, and then we take that relaxing breath again. We also have effleurage, which is a light circular stroking on the outside of the stomach during the actual contraction itself. And again, we're using that sense of touch to provide a distraction. Counter pressure, this was one of my favorite things during labor. I had kind of a back labor with baby number 2, and so using something like a rolled up towel, for me it was more of that tennis ball. It was, this type of therapeutic touch. This is a therapeutic touch. Counter pressure provides a therapeutic touch, and it's trying to reduce the muscle tension and the fatigue. Again, when we have these options, it increases that woman's sense of control, and that greater sense of control is going to help reduce anxiety. Touch, massage, each that might be more applicable at the beginning of labor, during that stage 1, because by that third phase of stage 1, where you're in that transition, you don't want anybody touching you. Don't touch my feet. Please don't touch my feet. We're trying to decrease the tension. We're going to increase comfort. So application of heat and cold. So again, basically we only do heat typically. Heat really feels good. So warm blankets, compresses, showers, getting in the shower if we're able to be up and mobile, and point that shower head at that lower back or over the abdomen. If we're laboring at home, if the waters have not broken, doing a bath is also a good way to provide that application of heat. It increases that blood flow to that area of discomfort. We basically only use cold if a woman feels hot or warm during labor. We don't use it so much for pain management. So we're going to talk a little bit about acupressure and acupuncture. Those can be used as well for non-pharmacological pain management. The TENS, so the transcutaneous electrical nerve stimulation, has some reported effectiveness in early labor management pain, and it's thought to manage pain by modulating sensory input, and it's fairly inexpensive. As far as water therapy or hydrotherapy goes, just a reminder here that we're going to have no internal electrodes. That would be no bueno. No internal electrodes for monitoring during that process. The intradermal water block uses small amounts of sterile water into 4 locations of the lower back, right about the same spot where you would see these TENS applicators applied. There's some unproven effectiveness, but really there's no serious safety concerns associated with it. And again, it's utilizing that gate control theory of pain. If a woman is concerned about the stinging sensation in her lower back, perhaps we'll be less concerned about the dilation in the cervix. Other things that are commonly used include aromatherapy, music, hypnosis. You can also utilize some biofeedback techniques. All right, so now let's talk about the pain medications, the pharmacological pain management. So most non-opioid drugs, such as acetaminophen, have very limited efficacy in active labor. Please do not give me 2 Tylenol and give me a pat on the back, okay? As well, we try to avoid the oral route of pain medication administration because we've got some delayed gastric emptying. During this whole process of the labor, your whole body is focusing on this one task. So a lot of stuff going on in your stomach is not going to be a real high priority on your body's list, so you're going to have some delayed gastric emptying. We also have a slower onset of action that we already know when we have oral pain medication, and we also really don't want to cause nausea. So most of our medications are going to be given IV, if not IM. So sedatives relieve anxiety and these induce sleep. We might use them in prolonged labor if we have that prolonged latent phase where we're starting to see some cervical changes, but things really aren't progressing the way that we need to. We've got ineffective hypotonic contractions. We're going to induce some sleep here at this point to help. However, with that being said, we only use them if we anticipate that delivery is not going to happen for at least 12 hours. Because honestly, if these medications, if sedatives are given too close to that delivery time, the fetus is going to be born and no longer has the placenta to filter those medications, is going to have them on board. And then if infants are born sedated, what are you going to do? Are you just going to give them Narcan? Well, no, we don't. We no longer use Narcan. But instead we would use positive pressure ventilation, or PPV, and they've probably bought some time in the NICU as well. Anesthesia is going to provide some temporary interruption of the conduction of nerve impulses, or what we recognize in our brain as pain. Pain perception can be alleviated, but we don't want to do that at the cost of losing consciousness. Essentially, we only use general anesthesia during an emergent or a stat section. For example, if we have a mom code, during the laboring process. That will do a stat section, general anesthesia, because it's quicker to get administered if we don't have a spinal line already in. If we're starting to lose fetal heart tones, again, stat section. So the problem is with general anesthesia that we need to get that baby out and delivered as quickly as possible after the induction of general anesthesia, because again, this is crossing the placenta. It's crossing the placenta, being absorbed by the fetus, and then you take the fetus away from the mother, and then that it takes a little bit for that liver in the baby to become fully effective, to become fully matured, and you have basically taken back their secondary filtration system. So anesthetic agents, CNS depressants, are administered during general anesthesia, and we really need to get that fetus out if we're going to have to do that during a stat section. We would very, very rarely use these for an uncomplicated vaginal delivery. I would assume, honestly, if these medications were used for a vaginal delivery, somebody would be pulled before a review board to discuss why they chose to use these. Now, when we're talking about analgesia, okay, so analgesia is a little bit different, okay? So we're not going to lose consciousness. We're going to have regional or systemic relief, okay? Opioids can be given, so IV, IM, PCA, so Dilaudid or fentanyl. I'm going to get on my soapbox here for just 2 seconds. So a lot of new graduate nurses end up in roles in the emergency room. It's not a bad place to start to learn, but one of the things that happens in the emergency room sometimes is the concern about the medications that we are giving and whether or not they affect mother's breast milk. I want you guys to remember, when you are in the emergency room and you're delivering Dilaudid to a mom who's, broken her leg, and she's still breastfeeding, her baby is 5 months old, and you're like, should she pump and dump? Should she pump and express her milk, dump her breast milk, and not give it to the infant? Remember that we give these drugs to laboring mothers, okay? So if we're not concerned about them affecting the fetus during labor, then, or even after delivery, and we're using Dilaudid to help manage pain in a post-C-section on a PCA, then for Pete's sake, give them their pain medication and don't tell them to pump and dump. If you ever have any questions about whether a medication would cause a mother to need to pump and dump, then you call lactation and you get some help from somebody who's more of an expert. Pumping and dumping, if you've ever pumped breast milk, it can be quite trying to express out maybe 3 ounces of milk and then being told to just dump it. It's like gold being dumped down the sink. So anyway, like I said, that's my soapbox. Okay, so fentanyl. Why are we using fentanyl? Well, we're using fentanyl because it's fast acting. It acts really quick, gets us the pain relief that we need. It's got a very short duration time. So we've got these women comfortable for the second that we need them comfortable in order for them to be able to labor and push that baby out. And then once that baby is out, we no longer need that pain medication on board. Opioids provide that temporary relief. They do cross the placenta, so we do need to keep an eye on it. That's why anesthesiologists are on board. They're the ones who are ordering these pain medications, because we do need to be aware that they can cause some decreased fetal heart rate variability and some neonatal respiratory depression. But for the most part, we don't see too many issues related to the opioid use during labor for the fetus. Some side effects for mom include respiratory depression, just like you would see respiratory depression in too much opioid use in any other way, any place else in the hospital. Itching, nausea, and vomiting. So Benadryl is typically available for us to give in the postpartum unit just because of the potential for itching following the opioid medication use. So when we're talking about analgesia, there's localized pain relief and motor blocks. So when we're talking about local, for example, we're going to talk about this pudendal nerve block. So a pudendal nerve block is trying to focus on the pudendal nerve that is right here, located near those ischial spines. So the provider is going to reach through that vaginal cavity and is going to feel for that ischial spine, feel the tension for the sacrospinous ligament, and going to go ahead and inject into right close to that pudendal nerve. And that is going to help with, that's going to help with some of that pain, that somatic pain that's occurring towards the end of the laboring process. It can be used during an episiotomy. It can also be used during a forceps delivery, where we're going to be putting even more traction on those adjacent structures, and during a vacuum delivery, or you might hear it as a kiwi. Remember that as well. So that takes about 10 to 20 minutes to be effective. It's not, remember, it's being localized down here to the lower vagina, the vulva, the perineum. It is not affecting the uterus at all. Okay. We also talked about prior to the episiotomy how we're going to inject that xylocaine, and so remember that that can be administered prior to an episiotomy. And is more frequently used from what I have seen for an episiotomy. The epinephrine is mixed with the lidocaine. Why? Well, the epinephrine intensifies the anesthetic effect of the lidocaine. It prevents excessive bleeding. And the other part of it is that it constricts the blood vessels around that injection site, which really localizes the effect of that lidocaine and prevents it from becoming systemic. Neuraxial analgesia, which we'll talk about here next, is talking about those epidurals and those spinals. So epidural and a spinal, these are given are placed into the lower back here, and neuraxial or the spinal is typically reserved for C-section deliveries and not for active labor pain management, because it does provide a complete paralysis. So if you're looking here, we're going into the epidural space versus the lumbar space, okay? So when we actually are into this CSF, we're doing that whole we're not, that whole area. When this happens, the woman is numb from the area of insertion to lower, so usually around the nipple line. So in this case, the laboring mother can be awake during the C-section delivery, but isn't going to feel the cutting and the surgery for the C-section. The epidural is one of the most requested and frequently chosen pain medications currently, or pain management options, methodologies for the laboring mother. So you're going to have an insertion of a catheter into the lumbar epidural space using a sterile technique. Through the catheter, through here, the needle is obviously going to be removed, the catheter stays in, and we're going to administer that local anesthetic, opioid, or a combination of both. So usually we're going to numb up this area with lidocaine. They're going to give you perhaps an opioid medication through here, again, that fentanyl versus that Dilaudid, give you a break, give you a momentary relief, and then we'll titrate that dose down to something that's just managing your pain. It's still allowing you to feel your contractions. It takes about 20 minutes to become effective. It allows for continuous epidural anesthesia, and it prevents contraction pain for the duration of labor. Now, if at all possible, like I said, you want to titrate that dose down so that the patient is still able to have some sort of feeling. As as we already know, once they feel more, they can do more, like with that Ferguson reflex. So when you're assisting with an epidural, it is, like I said, a sterile procedure. This nurse here at the bedside usually is going to have a hairnet as well. And in our COVID world, where everybody is going to have masks on, the epidural space is that this lower back here is then cleaned. We have that lidocaine being administered, and then we'll have this sterile drape applied along with the povidone iodine. The patient is completely draped up. We're going to assess those vital signs prior to insertion of it. After the catheter has been inserted, so you can kind of see this tubing that's coming down right here for this patient, that's going to be hooked onto that catheter. If at any time that catheter becomes dislodged from the tubing, you never pick up that epidural tubing and clean it with alcohol, because as soon as you attach it, it goes right into that spinal area, and it can like kill the nerves in that spine. So obviously you don't want to be doing that. And that's a good little tip to hang on to moving forward, because I've seen epidurals used for other procedures. I've seen them used for abdominal surgeries in my pediatric patients, and also sometimes for joint replacements. So with all of that being said, so we do an epidural and we're done? We're good to go? Okay, no. There is a concern. You have to be watching those vital signs closely, because one of the main side effects of an epidural is hypotension. Well, you're only going to notice about hypotension if you have baseline vitals rolling, right? You can also see a significant increase in the systolic blood pressure or the heart rate, which would indicate an inadvertent injection into a blood vessel. So again, potential side effects, hypotension. So it's not uncommon for these women to be bolused prior to receiving their epidural. Nausea and vomiting, itching, decreased peristalsis, urinary retention, respiratory depression. And when we're talking very specifically about spinal, we can talk about impaired placental perfusion and a post-dural puncture headache. So all of those potential side effects essentially are related to opioids use. So what are some contraindications to the use of any of these nerve blocks? Well, if we're concerned that we're going to have a maternal hemorrhage, this is not the time to be placing an epidural. This is the time to be putting that woman under general anesthesia, perhaps, and sending her back to the OR. Maternal hypotension. If we already have existing hypotension, are we going to create a situation where we can perhaps drop her blood pressure even further, thus decreasing the amount of perfusion that she has, decreasing the amount of perfusion to the baby, to that fetus that she's carrying? Absolutely not. If we have maternal coagulopathy issues, if we have a known platelet disorder, are we going to introduce other methods of bleeding, potential bleeding risks? Infection at the injection site, I think that's kind of a no-brainer. Increased ICP, again, these women who have, what is it called? That Charcot-Marie-Tooth syndrome. Anything like that where you have some of the dura of the brain that's already imposing upon the spinal column, they don't want to do that. We're not going to go anywhere near that. Those patients are going to undergo general anesthesia. Thrombocytopenia, that goes along with the coagulopathy issues. Allergies to anesthetic drugs, maternal refusal or inability to cooperate, and some cardiac conditions. Again, some of that is self-explanatory. So nitrous oxide for analgesia. So nitrous oxide is used in the UK, Australia, and in Canada, but not routinely used in the US. You can see it in those alternative birthing centers. It's commonly called laughing gas. It's composed of about 50% nitrous and 50% O2. Again, this is going to increase the woman's sense of control during the laboring process, because nitrous oxide is self-administered. So the laboring mother will inhale the gas through a mask held over the nose and mouth, and the nitrous oxide is tasteless, odorless, used as needed, and it also allows for freedom of movement because we're not hooking her up to an IV pole. It induces relaxation by reducing anxiety, likely reduces pain perception. Again, we're talking about that gate control theory of pain, and it's hypothesized to have an opioid-like effect on the CNS. It's useful at any point during labor, including during perineal repairs, thus reducing the need for lidocaine. It has a very rapid onset of action within 1 to 2 minutes. Nitrous oxide does not cross the placenta, so no harmful effects upon the fetus. It does not accumulate in the fetal body, so again, this baby is delivered and is able to start that transition process on their own without needing to expel a gas. There's no differences in APGAR scoring or NICU admissions between those that use nitrous oxide versus those who did not. Some mothers might complain of nausea, and some may also complain of some temporary sedation.